So in the first section, we mainly talked about the molecular pathogenesis of the colorectal cancer, or what are the changes at the molecular level that leads to the development of the colorectal cancer. So in this section now, let's talk about some risk factors, which might be dietary risk factors, or where it might be polyposis coli or formation of the polyps in the colon that can progress into the colon cancer. So, or the hereditary non-polyposis colon cancer. So we will all discuss all these risk factors which can ultimately lead to the development of the colon cancer. So the risk factors, since it's the colon or lower GI tract, and food plays very important role, you will see a lot of the food nutritional factors are included in the risk factors for the development of the colon cancer. So the risk factors, we have diet is the first and the foremost, especially the animal fat, red meat. Animal fat products can cause the development of the colon cancer. So it's the risk factor for the colon cancer. Diet, including the animal fat. Polyposis coli is the condition in which multiple polyps are formed in the colon. Then we have MYH-associated polyposis, Lynch syndrome. Then we have inflammatory bowel disease, Streptococcus bovis bacteremia. And then we have the tobacco use is also associated with the colorectal cancer. So all these are the risk factor for the development of the cancer, colorectal cancer, and polyposis is very important factor. Polyposis. Osis is the condition of, and polyposis is the condition in which the polyps are formed, multiple polyps, and sometimes there is hereditary tendency to develop these polyps. So all these can lead to the malignant transformation, and it's one risk factor. Inflammatory bowel disease, we have the Crohn's disease, ulcerative colitis. These can have tendency to develop into the cancer also. Then we have Streptococcus bovis bacteremia. Is the condition in which there is infection or sepsis. Emia is infection when it reaches the blood, and it is caused by Streptococcus bovis. So this is also a risk factor for the colon cancer, and there is one syndrome associated with this known as the Lynch syndrome. And food products, especially the animal fat, red meat is not good, should be very limited in use because it has the tendency to develop the colon cancer. Then the animal fats in red meats and processed meat, increased anaerobes in gut, bile acids conversion into carcinogens, and there is high serum cholesterol. So what's the effect of the animal fat for the development of the colon cancer? These are the few steps, because it increased the anaerobes in the gut. Anaerobes are the microorganisms that can grow in the absence of oxygen. So there is increased anaerobes in the gut. There is conversion of bile acid conversion into carcinogens. Carcinogens are the chemicals that can lead to or substances that have the ability to form carcinoma, and there is also high serum cholesterol level. So all these are the factors that can lead to the cancer associated with high animal fat intake, which include the red meat. Then the insulin resistance, another dietary factor, insulin resistance. When there is resistance to insulin, insulin is the hormone that causes the metabolism of the glucose. So when there is resistance to the insulin, the glucose is not being metabolized and there is increased level of glucose in the blood. So there is increased glucose in the blood and organs unresponsive to insulin, less glucose being stored or used. So if there is resistance to insulin, resistance means the organs, they are not responding to the insulin and the glucose is not being utilized or metabolized, and this can cause increased level of glucose in the blood. So mostly this insulin resistance develop in people who are obese, who are overweight. There is increased level of insulin. Because of the insulin resistance, glucose level increases, and this increased glucose level have a negative feedback effect. Increased glucose cause the increase in the insulin, and there is increased insulin and high insulin level, increased IGF-1 level, insulin growth factor 1, and there is proliferation of intestinal mucosa. So increased level of glucose causes increased production of insulin, and more glucose is accumulated, not being utilized, metabolized, and there is increased proliferation of the mucosa of the intestine. So these are two dietary factors that can lead to the development of the colorectal cancer. Then hereditary factors and the syndromes which are associated with colorectal cancer. These are some syndromes which are associated with the cancer. So these are all the names of the syndromes. Then we have where these syndromes cause there is a formation of the polyps. What's the histological type? We already mentioned that adenomatous polyps have the more ability to convert into malignant cancer or malignancy or develop into cancer. So adenomas is the most common histological type of these syndrome. Then malignant potential and then associated lesions. Syndromes usually have some associated lesions, associated organs involved. So let's go over this chart that gives us the syndromes and the hereditary factors. So syndromes, we have familial adenomatous polyposis. This affects the large intestine or the colon. Adenoma, malignant potential is common and there is non-associated lesion. Then we have the Gardner syndrome. Gardner syndrome develop into large and small intestine. Then we have adenomas, malignant potential is common, and then the associated lesions in Gardner syndrome is osteomas, fibromas, lipomas, epidermoid cyst, ampullary cancer, congenital hypertrophy of retinal pigment epithelium. So all these are the associated lesions present in the Gardner syndrome. Then another syndrome is Turcot syndrome, and this involves the large intestine. We have adenoma, the malignant potential is common, and then their associated lesions are the brain tumors. Then we have MYH-associated polyposis. large intestine, then we have adenomas. Malignant potential is common, and there are non-associated lesions. Non-polyposis syndrome, Lynch syndrome. So Lynch syndrome is non-polyposis syndrome. It involves large intestine, it's adenomas, it's common, and the associated lesions with the Lynch syndrome, we have endometrial and ovarian tumor, gastric, genitourinary tract, pancreatic, and biliary cancers. So Lynch syndrome is also have so many associated lesions. Peutz-Jeghers syndrome, it involves the small and large intestine and the stomach. The histological type is hematoma. It's a rare malignant potential, and there is mucocutaneous pigmentation, tumors of the ovary, breast, pancreas, and the endometrium. And then we have juvenile polyposis. Juvenile is the young age, so it involves small and large intestine and stomach. Histological type is hematoma, rarely progressing to adenoma. Malignant potential is rare, and there are also various congenital anomalies associated with juvenile polyposis. So it's a very good chart describing all the syndromes which are associated with different types of polyps and different types of lesions involving the small intestine, large intestine, and the stomach, and also associated lesions with these syndromes. Polyposis coli. Polyposis coli, if you see, these are all the different polyps present in the descending colon. This is the descending colon, and you can see different polyps present, and this is polyposis coli. And once quickly mention, colon is also the large intestine. It's large because of the size of the intestine, large because of the width of the cavity of the large intestine. It's not large because it's more in the length. So make sure that small intestine is larger in length as compared to large intestine. Only it's large because it's more in the width. So these are the polyps present in the descending colon. So polyposis coli. Adenomatous polyps, defect in colonic mucosa, autosomal dominant due to spontaneous APC mutation or deletion. So we already mentioned that there is a mutation in APC gene that can cause the cancer. So there is also in this mutation. So polyposis coli is autosomal dominant, so it's a hereditary condition, and there is adenomatous type, and there is mutation in the APC gene. Gardner's and Turcot syndrome are the two syndromes which are associated with the polyposis coli. There is impaired DNA repair, total colectomy, non-steroid anti-inflammatory drugs, and also selective cyclooxygenase 2 inhibitors. So there is it can be treated by the total colectomy or total removal of the colon because it's a hereditary condition. There are very lot of polyps present here if you see. So total colectomy is the total removal of the colon, and then there are non-steroid anti-inflammatory drugs can be used, and also selective cyclooxygenase 2 inhibitors. Flexible sigmoidoscopy, proctosigmoidoscopy can be used for the screening. Sigmoidoscopy, examination of the sigmoid, colon, or procto. Procto is the term used for the rectum, or proctosigmoidoscopy. In both the rectum and the sigmoid colon are examined. MYH-associated polyposis. Here it's a rare autosomal recessive syndrome. So polyposis coli was autosomal dominant. This is autosomal recessive, and these are the polyps present in the colon. Biallelic mutation in MUT4A gene. So this MYH is due to mutation in MUT4H gene. Variable clinical presentations associated with MYH polyposis. Without polyposis, colectomy is the treatment used for the MYH-associated polyposis. Hereditary non-polyposis colon cancer. Here, these are the stages of the hereditary non-polyposis colon cancer. It is divided into 4 stages. We have stage 0, 1, you see it keeps on progressing and progressing, 2 gets bigger, 3, and the stage 4. And this, it spreads to the other organ in the stage 4. So stage 4, it spreads to the other organs of the body. This autosomal dominant, again, as the polyposis coli. This is also autosomal dominant condition, but it's non-polyposis. Germline mutation, and in this the mutations are in the HMLH2 and HMLH1. Cancer in the proximal large bowel. Poorly differentiated cells are present. So poorly differentiated, not well differentiated, that what type of cells are present on the histological examination. So it's the mainly it's the cancer in the proximal large bowel. So proximal large bowel may be more common in the ascending colon and then the transverse colon. It's mucinous in type. Screening is again by colonoscopy, pelvic ultrasonography, and endometrial biopsy. This endometrial biopsy is helpful when it is in the late stage. When it spreads to the other parts of the body, then endometrial biopsy is also effective. So these are the stages 1, 2, 3, and 4. 4 when it spreads to the distant organs, and initially it spreads to the this is here you can see the margins or the lining of the colon wall. We have mucosa, then submucosa, then the muscle layer, and then the serosa. Then we have the blood vessels and the lymph nodes. So in stage early stages 2, 3, spread to the regional lymph node is present, but in the stage 4, along with the lymph nodes, it can spread to the different organs of the body, and then endometrial biopsy can be effective. Associated cancers of hereditary non-polyposis is we have ovarian or endometrial carcinoma, gastric tumors, small bowel tumors, genitourinary tumors, we have pancreaticobiliary tumors, and also sebaceous skin tumor. All these are the tumors associated with non-polyposis colon cancer. Inflammatory bowel disease, we have it's associated with large bowel cancer. These are the two inflammatory bowel disease. We have Crohn's disease, in which there are patches of the involvement of the colon, segmental involvement, and the whole portion is affected. It's ulcerative colitis. Here again, this is the healthy colon, then we have the Crohn's disease, and then we have ulcerative colitis. So it leads to large bowel cancer. Ulcerative and Crohn's disease are the two types of inflammatory bowel disease. Risk more with pancolitis. If a whole colon is involved, there is increased chance that it can become malignant. Symptoms are bloody, diarrhea, cramping, and obstruction. So it's very important we should pay attention if there is blood coming out of the rectum, there are bloody stools present, tests should be performed, and look for any abnormality, masses present, because bloody diarrhea is not good. So anything, if you notice bloody diarrhea, make sure to follow up it properly. Cramping and obstruction is also associated with the inflammatory bowel disease, and both of these can progress to cancer, and especially when it's pancolitis, complete involvement of the colon, it can have more tendency to progress to the cancer or malignancy. The colonoscopy with mucosal biopsy, surgical removal of the colon is done for the screening. Other high-risk conditions include Streptococcus bovis bacteremia, those having endocarditis or septicemia, fecal bacterium, occult colorectal tumor, cause upper GIT cancers, endoscopic or radiographic screening. Then we have another tobacco use is more than 35 years of tobacco use, and it can cause colorectal adenomas. So these are two other conditions which are associated with the GI tract cancers. We have the infections caused by Streptococcus bovis bacteremia, and when there is bacteremia or septicemia, the infection can spread to the different parts of the body through the bloodstream. So there might be endocarditis or the septicemia. There is occult colorectal tumors. Occult is hidden, so might be hidden tumors present, and the diagnosis is by endoscopic or radiographic screening. Tobacco can cause the cancer, especially after 35 years of the smoking or tobacco use. And then colorectal adenomas are the type associated with the tobacco use. So this was all about our section in which we talked in detail about the risk factors associated with the colorectal cancer. Thank you for watching sqadia.com.